Thanks very much for giving me the opportunity to come along today. I think what I'm hoping to cover is just outline a little bit about why we believe we need to change, not just in the Northeast, but also in Scotland. Spending a bit of time about the framework that we've developed that helps us engage with our partners, so to ensure that we are speaking the same language when we talk about population health and prevention and what we're trying to achieve. We, I think, are building on really good examples of joint working here in the Northeast, so I've tried to put some of those into the presentation, but absolutely hoping that we've got a lot of time at the end to talk about what we can do together to tackle some of the challenges that I'll just outline. So again, I'm not sure who all's on the call, and you've probably got a degree of background information about the health of our population. So apologies if I'm teaching you to suck eggs. But after decades of improvement, Scotland and indeed Grampian's health is worsening. People are dying younger. The life expectancy in Scotland is one of the lowest. It's the lowest in the UK and one of the lowest in Western European countries, and our local authority areas are pretty middle of the pack in Scotland, so we're middle of the worst in terms of our life expectancy. We're also seeing the number of people dying earlier increasing, and that again can be attributed in part to some of the stalling of the preventative activities we'd done previously around coronary heart disease, but also seeing an increase in deaths from substance use and suicides. We're also seeing people are spending more of their life in ill health. And again, I often get well, why do we want to support people to live longer? Because actually you've got to die of something. But what we are seeing is that more of our time is spent in ill health. And if we look at the data for some of our females in our population, that can be nearly 2 decades. So it's a significant amount of time we are living in health that could be improved. And if you're a male living in one of our most disadvantaged areas, you are likely to die on average 10 years earlier than those living in our more affluent areas. And you can see from this chart, whilst many people might attribute the worsening of our poor health to COVID, actually the decline was starting well before the pandemic. Looking at inequalities, again, we've looked at a range of, so what are people dying from, and regardless of the disease, there is a clear message that those living in our disadvantaged areas are dying 2 or 3 times more likely from a range of conditions than those living in our affluent areas. So not only are we looking at supporting increasing life expectancy, tackling more years in good health, absolutely fundamental that we tackle the inequalities that we are seeing in our communities. And here again, just to highlight the difference that we see, and we have got difference within our patch. So Aberdeenshire faring slightly better than Murray and Aberdeen City, but again, just looking that a man might expect to spend 14.3 years in poor health and women 17.3 years. So often what we do is we look back and describe a situation, but a report, the Scottish Burden of Disease, it's helping us to look ahead to, so if we don't take action, what might happen? And essentially the report is saying that by 2043, despite the fact we expect a reduced population in Scotland, we will expect to see a 21% increase in illness in our communities. And we know you just need to look around. I nearly didn't make it today because of the pressures in our system. We have an absolute mismatch between demand and capacity, and we have insufficient resources to deal with such an increase in ill health. We can attribute 2/3 of the increase to cancers, cardiovascular disease and neurological conditions, and many are amenable to intervention either through preventative initiatives or early intervention. When we look at the absolute burden, that's likely to appear in the 65 to 85 age group, and we know we've got an ageing population. But what I often remind, I haven't got my glasses on, so I don't know the average age in the room and online today, but in 20 years' time, actually the 45-year-olds of today will be the 65-year-olds of tomorrow. So we absolutely need to focus in on what we call the life stages. We spend a lot of time in health talking about the best start in life. We spend a lot of time looking at our frailty pathway, but actually what this demonstrates that if we're to get serious about prevention, we need to look across the life course. And the final key message out of this report is that the level of illness will be double in our disadvantaged areas, so just reinforcing the importance of tackling inequalities. I was saying to Connie, it was a CMO meeting last week, and the key statement that caught my hearing was traditional public health methods haven't worked. And I'm just putting this up here to say, actually, we can demonstrate how public health efforts can make a difference. So if we are looking at whether it is implementation of new vaccines, such as the HPV vaccine and the 89% reduction in pre-cancer cervical cells between 2008 and 2014, whether it's national policies that have been developed, such as minimum unit pricing, which you'll be all aware of, or indeed I've selected Child Smile because Child Smile is a programme that was developed by a local oral and dental health team. They recognised that they were catching children way too late when poor oral health had set in. So a programme of toothbrushing introduced in nurseries, preschool, supply of toothbrushes and toothpaste done at scale saw a 50% reduction in tooth decay amongst children. Now, when we think that the biggest reason for children to be admitted into hospital on a planned basis is poor oral health, we can absolutely reduce the suffering of the individual, but also the pressure on our system. So we know we can do something, and we've seen that historically, but often when I talk about tackling child poverty, people will say, well, that's the job of the local authority, isn't it? Nothing to do with us in health, nothing to do with us in academia. So what we've selected as our framework is the 4 pillars approach that's been developed through the King's Fund. And the figure in the middle here is often dubbed the Marmot Man. And what that is really just setting out is that our health is determined by our social and economic factors, so our education, our employment, our income, our physical environment, air quality, housing, transport, as well as behaviours such as substance use, our healthy diet, sexual activity, as well as access to high quality healthcare services. So when people talk about health in the groups that I've been in previously, we often talk about health and we equate it to access. So an example would be The importance of good mental health for children and young people, absolutely. And we tend to follow that with access to CAMHS services. So what we're hoping is that this framework will allow us to have conversations that look at the balance. Absolutely, access to healthcare is important, but we need to have interventions that tackle the wider determinants of health, as well as the lifestyles and places. But equally, the diagram sets out that we can't do this in isolation. We do need to work together, and aware that a number of people will be familiar with a healthy weight issues in our region. So 3/4 of adults are overweight or obese, and nearly 1/3 of children join primary 1 are at risk of overweight or obese. But it's not an individual choice for a primary 1 child. It will be parental influence. It will be the environment, having good quality, affordable food available within their localities. Yet we know from work that we've done that actually if you live in our disadvantaged areas, you will have greater access to tobacco, to alcohol, to unhealthy foods. So we need to work with our local authority partners to use planning legislation. We need to work with individuals and communities themselves. We need to work with business. So there's a range of partners that need to come together to enable us to deliver our ambition of improving population health, tackling health inequalities whilst improving and sustaining our health and care system. So we've set about having conversations with partners around how would we create a population health system? Because I think, I'm sure many of you are familiar that when something's everybody's business, it's not really anybody's business. And actually, we need everyone to have that collective sense of responsibility so that they take action within their own organisations, but they also look to opportunities to work with other partners to deliver improved health. So we got leaders together from public sector across the North East and created something called the North East Population Health Alliance. And what we've done, and I'll just take you through that very briefly, is we've set out the case for change in my DPH annual report, and a huge thanks to Corrie for the work that she did on that. We've worked with them to articulate a vision, so that common purpose of what we're trying to achieve. We've taken them through how do we describe population health, and we've agreed to use the 4 pillars framework to conceptualise, operationalise and prioritise how we will deliver that vision. And finally, and this is where I really hope you will be able to work and support us, is there is no blueprint about how to do this. We do need to take the best evidence that's available with the local knowledge that we've got to co-create some different ways of doing things, test them out, and where they work, look to spread them at scale. So that's the purpose of the Alliance and why we're coming together. So if we take us back a little bit then to the population health threats, I've outlined the status of health in Grampian, which mirrors that in Scotland. And we looked at, so what's coming over the hill? What are the things that we need to be prepared for? And the 4 key threats that we do need to ensure that we take action on are the higher cost of living, and clearly we had a bit of a double whammy with the COVID pandemic and the economic impact that's had, with the EU exit, raising, having a much higher cost of living, salaries reducing, investment staying the same, means that we are seeing an increasing number of our population moving into poverty, but those already in poverty are moving into really significant financial challenge. And if we put that into perspective, about 1 in 8 of our children are living in poverty, and about a third of those, their families can't afford to give them sufficient food every day, and that is having an absolute impact on their health now, but also their health in the future. But it's also easy for us to try and segment and think, well, those living in poverty all live in our areas that are designated disadvantaged, but that's not the case in the North East. 85% of our income deprived don't live in our most disadvantaged areas, and indeed every ward in Grampian has a child living in poverty. So this isn't about just targeting our interventions. This is about providing a universal service that is sensitive enough that can support individuals with additional support where it is required. I touched a little bit earlier around the increased need and demand for health and social care and community support services. And again, if I look here in the North East, the funding coming into Grampian, if we were getting the same level of funding as Tayside, we would have an extra 100 million per annum, but we don't. And it means over the last 30 years, our funding levels have been lower than other areas, which means some of the softer targets of increasing efficiencies have already happened in our service. So we are looking at whole-scale reform about what and how we deliver in the future. The salami slice approach is not an approach that is one that will work for us within the North East. You will have read in the media around re-emergence of infectious diseases such as measles. So we do absolutely need to continue to pay attention around protecting the health of our population. And we just recently signed off our joint health protection plan that we developed in collaboration with our 3 local authority areas. And then finally, it's not just about human health, but also the health of our planet. And many of us will have seen the direct impact of climate change through our weather systems over the last few years. So we set out here the key areas that we need to work together on, and in chatting to the leaders in the system, and this is again something else that we would benefit from some help on. This is a bit of a working vision where we were trying to set out about improving the health of our population without using the word health, because everybody in the room associated health with the NHS. So we came up with the vision is to have flourishing communities and recognition of how important place is, but enabling people to live fulfilled lives. And also a commitment that partners would undertake to work together to deliver that ambition, which again, I think is incredibly important. It's not one that you see in all areas across the country. So to help us understand our system a little bit better, we thought, well, let's do a bit of a deep dive into higher cost of living. It was important to all of us. We all had action on it, but we wanted to understand how our system was working. So huge thanks to the HDRC, who pulled together an evidence briefing around if we're tackling higher cost of living, here's the things that we should focus in on. We got partners together, we've got members of the public, the third sector, public sector together, and we wanted and talk them through against what works, what is it that we're doing in terms of our current activity, what's going well, what are the challenges and barriers, and what do we need to do differently to either increase the effectiveness or scale up the pace of activity as to what we are doing. And what came out of that, as you would imagine, is that there was an awful lot of activity going on, and we mapped that against the 4 pillars. As you can see, quite a lot in the wider determinants of health. But what did come across is we hadn't got the balance right. And when we were looking at our integrated health and care system, being able to clearly articulate what is the contribution of the health service to tackling inequalities was something that was a gap in our work around tackling the higher cost of living. But we also identified that there's a number of agencies doing the same thing with the same population. So there was an opportunity for us to collaborate more effectively. So the learning that we got from it was that actually we did need to collaborate, because we had a number of third sector who were seeing an absolute increase in requests for the services that they offered. But the funding model of the third sector tends to be year on year. So for them to be able to sign up to a new lease to deliver an increased volume of activity wasn't possible. And so if we could, public sector working with the third sector, identify how we provide accommodation. These were some of the real practical barriers that get in the way that might not require more money, just requires us to work better together. We also find that people didn't really know what else was going on in their community. So actually having the opportunity to come together to talk about the work that they were doing enabled them to make connects with other groups, and enabled them to provide what we call that wraparound care around members in our community. So really helpful benefit around sharing knowledge across the system. But when we go to make arguments about spending more of our time or more of our money on activities, we need to be able to demonstrate the impact that it's had. And quite a lot of the activities that were happening, people felt good about. They felt it was making a difference, but actually the tangible evaluation wasn't available to demonstrate the impact that some of these services have had. In fact, the majority of the services have had. Now, some of that wasn't the services' fault, because we managed to put in our system information governance barriers in the way, so people can't share data. They find workarounds, but it then means that they can, if you're a signposting service, you then can't follow up whether the individual picked up on where you directed them to. So huge amounts of work, I think, for us to do to change the system that we work in to be more supportive, but also to increase the support and skill to be able to evaluate and demonstrate the impact that these services are having. And then finally, when we looked at how people understood the needs in populations, how people targeted intervention based on those needs, there was quite a wide variety of what was called needs assessments, from what we in public health might call profiles right through to absolute needs assessments. So there was more work to be done to understand the difference within our population. So quite a lot for learning from us. We've taken that back, and we're currently working with the community planning partnerships about how we can remove some of the barriers to the work. So a lot for us to do around supporting our system to work more effectively together. But I thought what I would do is just quickly then take you through some of the other work where we partnered up with academic colleagues around the work that we are doing together. I'll skim over this, but there's some of the wider determinants of health and our work around being an anchor institution, and how we work with other partners to increase our community wealth building activities. But if I use this, one of the really exciting pieces of work that we've done, so we all know the impact of cold homes on both our physical and our mental health. We know that there are certain groups in our population who have greater health impact as a result of cold homes. And rather than, we're also aware from local authority colleagues that some of the support around insulation and services and support and advice that they provide isn't well taken up within our communities. So there was a real view of, could we in the NHS work with our local authority and our third sector to support individuals through the cold weather. And what we did was the NHS Grampian identified potentially eligible patients at risk of chronic conditions in our disadvantaged areas. They received an invite to participate in the programme. 544 people were invited, and just over 500 were eligible for inclusion. And we were able, with the support of partners, to provide 486 people with advice and energy credit to enable them to heat one living room and one bedroom to the ideal temperature over the winter. And the evaluation was undertaken by Sheffield Hallam University, and what we have found is strong positive effects in terms of self-reported feelings from those who participated, but actually we weren't able to demonstrate an impact on healthcare demand. For us in Grampian, we felt that this was a really, really useful way for us to identify patients in our service who could benefit from a more preventative intervention, and we will continue to build on that. But we're also looking at, so what more can we do this winter to prevent the demands on our front door? And I have to say, in sharing the evaluation of the warm homes and prescription, we do have people in our business communities coming forward wanting to support us to do and run this programme again next year. In terms of our health behaviours, again, not go into the detail. We've got a raft of work, whether that is on substance use, brief interventions around alcohol. We absolutely, as I said earlier, have got an issue around healthy weight, and we are looking at using the Leeds Beckett whole systems approach to healthy weight, and we're currently in the process of working with our community planning partnerships to identify the balance of that activity. We've tried that out within Aberdeenshire, and as we anticipated, majority of our efforts are focused in on one-to-one interventions and advice. And if I put it in context, our healthy weight management support services currently, we've got about 91,000 adults in Grampian who are obese. The services we deliver we've got sufficient capacity to support about 0.3% of those individuals. So we need to redesign our services, and we're working with Highlands and Islands around digitalisation of our pathway. But if I pick up on smoking cessation, again, looking at great progress has been made through policy interventions, but we haven't really made the difference that we aspire to in women who are pregnant and smoke. We've got around 500 pregnant women who smoke per annum, and our services aren't reaching them or aren't supporting them. So again, looking at how we can do things differently. But we're also seeing the inequality slant, and so we wanted to look at why our services are not as well taken up by those living in our more disadvantaged areas. So huge thanks to Lucia and others to support us with this. Interesting, what came back from this piece of work is the services that people wanted are actually the services that we provide. They just didn't know about them, and we perhaps aren't marketing them in a way that attracts people's attention and supports them and motivates them to take up that ask. So really huge and helpful piece of work. During the pandemic, we were introduced to your behavioural scientists, and I have to say we've never looked back. Some fascinating multidisciplinary discussions around how we position some of our health messages within Grampian. And we want to build on the good work that we have done. If I pick out vaping, again, many of you will, if you've got children yourselves, will see the absolute massive increase in vaping in children, by 22% increase in children vaping. There is no evidence, well, the evidence is disputed at the moment, but what is clear that whilst vaping may be less harmful than smoking, it isn't harm-free, and therefore it is not something that we would encourage, advise, endorse young people taking up the habit. So we wanted to get in upstream and look at how we could focus our activity with P4 and P5 pupils so that we can understand their intentions to take up vaping, so that we can develop appropriate interventions. And finally, I think I've probably overlabored the financial challenges that we're facing, but sometimes that can be quite hard to communicate in a way that doesn't strip out hope in the system. And so it was really fantastic to work with colleagues in behavioural science around how we can communicate the financial challenges and the roles that each of us can play to address them. Again, I've touched on places. I won't go into that. We have worked with colleagues in academia to pull out. So what is the evidence telling us around a place-based approach to health? We're building on that and supporting work through our community planning partnerships, and again through integrated health and care system. This is if you don't know it, this is Plan for the Future for NHS Grampian, and we are absolutely seeking to rebalance responding to illness with enabling wellness. And I've outlined on the left-hand side some of the activities that we're undertaking. But one of the areas that I'm again delighted to highlight some of our joint work is around understanding the factors that influence uptake of our screening programmes. We've been able to use that to work with the Grampian Racial Equalities Council to look at how we intervene and support and reduce the barriers to taking up the invite for screening programme. And finally, I touched on reform of the NHS. We do tend to think of planning health systems in, here's the problem, here's the solution, we just need to implement it and it'll work. But we all know it's much more complex than that. So we're embarking on a programme of reform within NHS Grampian, and we're currently in phase 1, which is looking at what are the lessons from elsewhere that we can build on in terms of this shift from continually responding to ill health to getting upstream around enabling wellness. Our plan for the future is quite high level. So if you walk onto the wards and say, what does plan for the future mean for you? They look and go, what? So again, we're doing some work around what is it that we are trying to achieve? What are those common goals that we can all sign up to wherever you are operating within our system. And finally, just again, being clear about what will our approach be moving forward. So some of the things that we're building on at the moment is engagement with colleagues and citizens. And by engagement, I am meaning an ongoing relationship development, not us coming out with a pre-prepared plan and having a conversation. So we've tested out new ways of working around going into communities and having conversations that's led by the community and seeing where that takes us. We've got a lot of learning in that for us, and equally we're looking at day in, day out, our staff have interactions with the public. They get feedback about what works in our system. And so we are looking at how we gather a real-time feedback loop, that we gather information, that we're able to analyse that, and then create those insights that enable us to change our system so it delivers a better experience and outcome for patients and for staff. I touched on learning, and again, we're working with Health Improvement Scotland around becoming a human learning system. Really, really keen that we take the evidence, we take our local data with our practitioners, our partners, and work together on new ways of working, test those out, learn from them, whether that is within individual wards or whether that is a system, and enable us to reform the health system as we move forward. So that was a really quick canter through. Here's just some of the partners that are involved with us in the North East Alliance, but equally a lot of the data and evaluation that we build our efforts on come from working with colleagues such as yourself, and I'd be, if time permits, really keen that we have a conversation about how we can do more of that together. Thanks.